Alright, so let's discuss about hemodynamic monitoring in children. So let's look at what is the overall context of hemodynamic monitoring. So whoever, all the healthcare providers who are working with critically ill children, hemodynamic monitoring is extremely important. Based upon your setting of work, it may be limited to your clinical and type of, it may be limited based on your clinical scope and the monitoring type of monitors available, but few concepts make the basic of hemodynamic monitoring. So we'll try to look at all those aspects. What is the context of hemodynamic monitoring, clinical parameters, and some core parameters which affect the hemodynamics, proper hemodynamics of the body, like venous return, preload. What is the preload assessment, and how is the cardiac output, how we can assess it. And one more way of looking at hemodynamic monitoring is looking at the microcirculation. When we measure some broad parameters like blood pressure, heart rate, arterial blood pressure, central venous pressure, these form the macrocirculation, where we measure parameters in and around the heart. And microcirculation is when we are trying to look at tissue perfusion, tissue oxygen utilization. Also, hand in hand, we'll keep looking at the ESPNIC guidelines, which were published in 2020. We gave us some statements on various aspects of hemodynamic monitoring in children. So context, basically, whenever there is a setting of impaired perfusion that is giving you shock, when it's impaired tissue perfusion, so that can happen in various situations. Particularly in children, what happens is that the cardiac output in settings of impaired perfusion, it can be variable. It can be low, normal, or high. Similarly, blood pressure can also be misleadingly high despite a low perfusion state. So it can be low, normal, or high. That depends upon the state of the systemic vascular resistance, whether the preload is actually low or there is you can say effective circulating volume is less because of excessive venodilatation, which happens in sepsis, in which the venous system becomes the capacitance increases and a lot of blood starts pooling into the venous system, and you get relative hypovolemia. So all sorts of situations occur. So we know that physical examination may not always be accurately giving us estimate of the actual cardiac output, actual good enough estimate of preload, whether we need to give more fluids or we need to fine-tune our hemodynamic interventions. Also, one more purpose of doing hemodynamic monitoring is that we want to titrate our therapy and to decide our therapy, whether we need to give more fluids or inotropy is needed. Inotropy means giving drugs which increase the contractility of the heart, like ADR, milrinone, dobutamine. Vasopressors, which predominantly increase the systemic vascular resistance. They are pressors, they increase your mean arterial pressure, like phenylephrine, norepinephrine, vasopressin. You can give dilators like sodium nitroprusside, nitroglycerin, inodilators, milrinone, levosimendan. These are good examples of inodilators. They give increased inotropy and also improve the diastolic relaxation of the heart, which is the lucitropy. And sometimes you might even have to give diuretics to improve perfusion, like furosemide and other diuretics. This is the basic interplay of various factors. For perfusion to be adequate, we need adequate delivery of oxygen and adequate oxygen consumption of oxygen, and a proper balance between these two parameters. So delivery of oxygen is usually denoted by DO2 and consumption is given by VO2. Delivery of oxygen predominantly depends on cardiac output multiplied by the content of oxygen, which is actually composed of the oxygen which is bound to the hemoglobin carried by the cardiac output, and some component of dissolved oxygen. But because the solubility coefficient and dissolvability of oxygen is very less, so it is multiplied by 0.0003. So contribution of that becomes very less in our overall calculation of delivered oxygen. So cardiac output, so basically hemoglobin becomes important in that sense. If you have a patient in shock, then you can ideally would like to have a reasonable hemoglobin most of the taxi guidelines and all say that around, in a relatively hemodynamically stable, you can tolerate around 7, but the child is extremely sick, a lot of dynamic status there. Ideally try to keep it between 7 to 9 and 10. In cases of traumatic brain injury, especially where any sort of hypoxia and it is can be very detrimental, ideally we suggest that you keep hemoglobin around 9 or 10 to keep your content of oxygen adequate. So cardiac output in turn basically depends. The other thing is cardiac output. So cardiac output is the one which is going to carry all of your oxygen to the tissues. So cardiac output depends upon predominantly stroke volume and heart rate. Heart rate can be easily measured. We can auscultate and clinically check the pulse and monitor. It keeps us displays the heart rate continuously. Assessment of stroke volume is a bit different. Stroke volume difficult depends upon 3 components: amount of the venous return coming to the heart at the end of diastole, all of the venous return preload, that is preload, which is the right ventricular and diastolic volume, that is this which volume will be causing the stretch of the right ventricular and the left ventricular and diastolic area, and the more you stretch it within limits, the more will be your contraction. That is given by the Frank-Starling law. And diastolic stretch increases the contraction. That's why we give bolus. When we give bolus, you increase the stretch. If you increase end diastolic volume, your end systolic volume also increases and the stroke volume increases. Afterload is the resistance against cardiac output is basically given by the left ventricular wall stress. Also depends upon any obstruction at the aortic area, tone and capacitance of the aortic area and the arterial system. If the afterload is elevated, cardiac index and cardiac output will be low. These are inversely related. Higher the cardiac afterload, lower is the cardiac index. That's why in cases of low cardiac output states, decreasing afterload becomes extremely important. And contractility is the state, the relative inotropic state of the heart, how strong, how it is the contractility, which can be measured by non-invasively by echocardiography, giving your ejection fraction, eyeballing some other objective parameter. And we can have some advanced cardiac output monitoring devices and various types of monitors which can give you cardiac output and some other parameters like stroke volume variation, systemic vascular resistance index, wedge pressures, and everything depends on whether you are using, say, pulmonary catheter, thermodilution, other modalities, or some non-invasive monitors like electrical cardiometry. Blood pressure we can measure by arterial or intra-arterial, non-invasive or invasive blood pressure. So clinically, whenever we assess the patient initially, assessment of brain and level of consciousness, orientation, recall, memory, these things, alertness, awareness, gives us an idea about the mental state and brain perfusion. If you have impaired perfusion, then your child may be lethargic despite being due to the hypoperfusion and inadequate oxygen supply to the brain. Skin gives us a lot of parameters like deranged CFT, increased CFT, which is more than 2 seconds is abnormal. Core to peripheral temperature difference, mottling, and kidney also urine output is extremely important parameter. Anything around 0.5 to 1 to 2 ml per kg per hour in children would, we will say, in combination with other signs of reasonable heart rate and blood pressure and warm extremities, not too much difference, and adequate urine output, would say that yeah, clinically most probably child is adequately perfused. So the clinical endpoints taught and given by various guidelines, normal is that if you try to restore the normal mental status, try to get to the threshold heart rate for the age of the child, try to restore the peripheral perfusion and try to get the CFT at less than 3 seconds. Your distal and central pulses both should be palpable if possible. Also, if your perfusion improves, then ideally your blood pressure for age should also come within range. If it is possible to measure, then cardiac index should ideally be between 3.3 to 6 liter per minute per meter square. Lactate and SCVO2 are some microcirculatory parameters. Lactate is a byproduct of anaerobic metabolism of ATP production. Lot of aerobic stress and can overwhelm the mechanisms in the enzymes which produce pyruvate. So pyruvate can get shuttled into lactate, and also in the setting of shock in anaerobic metabolism, lactate production can directly increase also. So lactate gives us a parameter marker of a microcirculatory dysfunction and lactate clearance. Suppose initial lactate was high, then clearance of lactate or followed lactate by 10% within 2 to 3 hours, then becomes a good parameter of that you are doing well with your perfusion. And SCVO2 will discuss in detail what is it. It's basically saturation of the central venous blood gas. Is giving you saturation of the venous side when it is come back from to the tissues, all of the oxygen which is coming back, how much is the oxygen utilization by the bodies in various areas. In urine output we already discussed. So as I said, two ways of looking at the parameters. One are the upstream or macrocirculatory, or downstream or microcirculatory. Not all are microcirculatory, but downstream is at the level of the tissues, and upstream in and around the heart. Blood pressure, heart rate, pulmonary capillary wedge pressure, central venous pressure, cardiac output, and urine output, lactate, base excess in the blood gas, tissue CO2, mixed venous oxygen, CO2 gaps are also recently coming into the picture to assess microcirculation. The venous to arterial CO2 gap and the ratio of this to the arteriovenous oxygenation, that oxygen levels, that also give us an idea about the state of the microcirculation or tissue oxygen utilization. As per the SPNIC guidelines, no single clinical parameter is adequate on its own. We should analyze several parameters and keep making frequent assessments. And initially we can perform clinical assessment as initial and keep evaluating along with some other parameters that you may have at your setting available with you. And do not titrate hemodynamic therapy or fluids all solely upon the clinical signs, or say example one isolated sign like a reduced urine output alone. You may use these parameters for some limited duration in the initial resuscitation phases. So the other core thing that we monitor in an ICU setting for sick children is arterial blood pressure. So intra-arterial blood pressure is recommended over oscillometric blood pressure measurement like the non-invasive blood pressure devices on the monitors in sick patients who have a dynamic status. It's a strong agreement. They've given a cutoff that more than 12 years target blood pressure more than 65, except for example child may be previously hypertensive, their baseline may be a bit higher. So but still blood pressure should not be used alone, it should be used combined with some clinical and hemodynamic parameters. Also in cases of shock, it's logical that vasoactive requirements we should use intra-arterial blood pressure. How we measure it is basically we put a catheter into the arterial system. It should be ideally should be a short, stiff catheter, non-compliant, and the tubing should also be short, stiff, non-compliant. So you have a PMO line, pressure monitoring line, which has a very good higher frequency, and non-compliant tubing which connects this blood flow from the arterial side. This saline keeps in this continuation to this saline filled tubing transmits this pressure to the pressure transducer. Pressure transducer is composed of a mechanism which converts this pressure signal into some electrical signal, and it is transported to the monitor and displayed an electrical signal. This is the typical arterial blood pressure waveform. Actually, the arterial blood pressure waveform is made up of very fine sine waves, which are very, very fine, lot of sine waves, and they are basically summated by Fourier analysis. Fourier analysis gives a summation of various fine short sine wave type of patterns and gives us a composite waveform like this. We get a systolic upstroke, there is a fall in the blood pressure, then the aortic compliance, it is called the forward compression, and this the other area of the dichrotic notch is called the backward compression. which is because of the compliance of the arterial system. And the dicrotic notch gives us a rough estimate of the closure of the aortic valve. And the area under this arterial blood pressure curve usually gives the cardiac output. So various monitors like pulse contour analysis, which use this mechanism of pulse contour analysis, they calculate cardiac output based on area under this curve. What happens is that there is a natural frequency in the arterial blood pressure system, and when you apply this transduce the system, put a catheter, the frequency of this our whole system, the tubing and the connections, should be at least 7 to 8 times the natural frequency of the arterial system. Otherwise all the frequencies will resonate and you will not get good readings. We'll come to that, how the pressure transducer works just a bit. The pressure transducer has a strain gauge type of pattern. Earlier strain this used to be the sign. It's a Wheatstone bridge principle, physics principle. There's three known resistance. These three are known resistance. This is unknown resistance. When pressure is applied, resistance decreases on one area, increases on the other area, and current flows, the voltage flows, and that is transmitted to the monitor. Nowadays, all these strain gauges are present on all the 4 parameters. You only apply a pressure, resistance reduces on one side and increases on the other side, and there is a flow of current, and that is displayed on the monitor. So 2 things are important when we are starting and using the arterial blood pressure system. We should have a good adequate frequency. How we do it? Frequency, because the natural arterial system, as I told you, that has a very high natural frequency. Actually this our arterial system that we're using, the tubings and all, they should have a high natural frequency, so that it is very high, 7 to 8 times of the natural fundamental frequency of the arterial waveform. For example, if the heart rate is suppose 180, so natural frequency must be at least 180 into 8 divided by 60 seconds, that will be 24 to 25 hertz. So it should be around 25 hertz to be accurate on, say, slower to higher heart rates. How can we calculate this? We give a fast flush test. This fast flush test, your paper speed is 25 millimeter per second, and we're using wavelength is around 1 millimeter, and this is giving you that this 1 millimeter wavelength in 25, so it's 25 by 1. This is the natural frequency, 25 hertz, which should be adequate. Another thing which the fast flush test gives you is the amplitude ratio, damping ratio. You divide the smaller, the A2, the second waveform length, divided by the longer A2 by A1. It should ideally be 0.78 to be optimally damped. If it is either under damped, if it is very low, it will be under damped. If it is high, it will be over damped. So if it is under damped, you will get systolic blood pressure overestimation and diastolic blood pressure underestimation. Usually the mean arterial pressure remains accurate. This is the optimally damped adequate dynamic response of the pressure transducer. This is the optimum response usually after the fast flush test. If it is over damped, then you will get systolic arterial blood pressure underestimation, diastolic overestimation, and mean arterial blood pressure would remain the same. 2 more naturally important things are leveling and zeroing. So leveling should be at the phlebostatic axis in and around the position of the right atrium, and zeroing is important to eliminate to tell the monitor that it has to regard the atmospheric pressure as 0. You close it to the patient side, open to the atmosphere, and zero it, so that the atmospheric pressure will be sensed by the pressure gauge transducer, and it will be regarded as 0. So whatever you measure after that, it will be taken above the atmospheric pressure, and this 760 or whatever that we have at your level, it will be regarded as 0. So leveling and zeroing are important. After every connection, disconnections, you should ideally keep checking your leveling and zero after each and every connection, disconnection, sampling, say for example change of position, these things. The other classically important thing is central venous pressure. Central venous pressure should be measured when your tip of the central venous catheter is at the junction of SVC and right atrium to get an optimal sample for CV measurement, or or a good SCVO2 sample, which is central venous oxygen saturation sample. It is recommended to be measured in unstable patients. It is not a good parameter for fluid responsiveness. It should not be used. No fluids should be given based upon CVP. Earlier days, there used to be various formulas like 2 and 5. You give bolus rise of CVP by 2 or 3 will give you an estimate of the preload, and you give bolus. But over the years, concept of fluid overload, congestion, extravascular lung water, and harmful effects associated with and limitations of CVP have to be understood. Not an accurate parameter for just for titrating your fluids. So isolated CVP has a limited value, but it can give you more information. What is actually CVP? It is not actually preload. Preload, as I told you, it's right ventricular end diastolic volume and LV end diastolic volume. Basically, so right ventricular end diastolic volume cannot be, say, measured. So we take pressure as a surrogate, right ventricular end diastolic pressure. Even measuring that is difficult, so you right atrial pressure is taken as a surrogate of right ventricular end diastolic pressure, which is surrogate of right ventricular end diastolic volume. So you see the limitations. So right atrial pressure, we say that is what we are measuring by measuring CVP. It is giving you a right atrial pressure, but we'll discuss that how it affects venous return and venous return also gives you its important component of preload. What are the various waves? Because we are measuring in and around the heart, right atrium. So it's a right atrial pressure. At the heart, one first positive wave is A wave because of atrial contraction. C wave is early systole. X is because of atrial early relaxation. Then V again is because of early ventricular filling, early diastole. The atrial pressure starts increasing just a little, and there is finally the wide descent because of early filling. And this is actually this V wave is late systolic filling. There are various waves, and they also correspond to various to the ECG. So the venous return, that I was saying, the actually venous return depends upon the difference upon the systemic filling pressure and minus the right atrial pressure, which is the CVP. So CVP is actually a hindrance to venous return. The less your RAP, right atrial pressure, the more will be venous return. That is how it is connected. Mean systemic filling pressure is actually the equilibrium pressure in circulation in static conditions. If you were to stop flow for a while, then there will be a mean pressure on the whole of the venous side. There will be one equilibrium pressure, that is the systemic filling pressure. And also we should know that CVP is taken as surrogate of right atrial pressure. Here this we are depicting that this peak, the mean systemic filling pressure, not peak, depends upon stressed volume divided by the compliance. CVP at zero flow actually is mean systemic filling pressure. VU is unstressed volume, VS is stressed volume. Stressed volume is the only which is contributing to the filling pressure, that is the descending pressure. That is actually the effective circulating volume. So whenever in case of sepsis, when your effective circulating volume is less, when you are giving bolus, what you are doing is you are giving bolus, because there's a lot of venous pooling in the venous system, you are giving bolus, you are giving fluid, extra fluid, so that what it will do is it will convert some of the unstressed volume into a stressed volume, and that may augment your venous return. If your PMSF increases more than PRA, then your gradient will be increased, venous return would be increased in only that condition. That is one way of increasing stressed volume, but that will cause fluid overload, extravasation, increase lung water. The other way of augmenting this stressed volume is by using vasoconstrictors like norepinephrine. That will maybe increase the tone of the venous side. So some of the unstressed volume would be converted into stressed volume, and you can augment venous return in that way also, without causing the harm related to fluids. So fluid loading increased, if there is increased systemic filling pressure, so venous return will only increase if this difference between the filling pressure minus the right atrial pressure, which is CVP, increases, or your resistance to venous return decreases. Resistance to venous return depends upon capacitance and compliance of the arterial system. At steady state, ideally, in a hypothetical Guytonian models, venous return is equals cardiac output, and we get vascular function and cardiac functions curves, which also depict this physiology in various ways. We discussed about central venous oxygen saturation. Basically, we are measuring SCVO2 in stable patients. What it is giving you? Usually a value of around 70%. Suppose your arterial blood side has a saturation of 100%. After oxygen extraction, your venous side, if it has around 75%, we say that around 20-25% extraction has happened. So anything around 70 is okay. SCVO2 of less than 65 suggests possible hemodynamic alteration. What in sepsis, sometimes a normal or high SCVO2 can also be there, but it may reflect tissue hypoperfusion and inability to utilize oxygen, mitochondrial dysfunction, and it may actually give you a sign that you have to look at further optimize the perfusion. It is not a standalone adequate marker for cardiac index, but it is in some way gives us in principle some idea. And the SPNIC guidelines recommends against targeting hemodynamic therapy solely based upon SCVO2. So there is one delivered oxygen. It depends. We all in the start we discussed cardiac output and content. Content here is predominantly by the oxygen bound to the. This is the per saturation of oxygen bound to the hemoglobin. So arterial system, it is delivering it. Some amount of venous consumption is happening VO2. After that, the returning blood has a saturation, which gives us an estimate of the level of oxygen extraction happening at that level. So mixed venous stats after various. The difference between mixed venous is when we are putting a pulmonary artery catheter that is measuring mixed venous saturation. The pulmonary artery catheter is advanced to the pulmonary artery, and where all of the venous return from the SVC, IVC, everything has returned back to give us a better estimate of the whole soul oxygen utilization of the body by various rearranging of these equations, where SVO2 depends upon is equals to saturation of oxygen minus the consumption divided by hemoglobin multiplied by 1.36, that is the bounding capacity, multiplied by the flow or cardiac output. So we can see by this equation that mixed venous saturation varies directly with oxygen saturation, arterial, hemoglobin, cardiac output, and inversely with the VO2. So whenever in a case of shock, potential hemodynamic instability, sepsis, cardiogenic, which may be any etiology, if your SCVO2 is low and your gross clinically blood pressure is low, cardiac output is low, lactate is low, impaired perfusion clinical markers are also there, your output is also less. If your SCVO2 low, we look at the two broad things. Look at whether the delivery of oxygen is less, maybe because of hypovolemia, maybe because of hemorrhage, it may be because of anemia, heart failure, hypoxemia, and look at the consumption. Maybe consumption has increased because of, say, hyperinflammatory state, fever, pain, shivering, increased work of breathing, agitation. And if in the setting of hypoperfusion, SCVO2 and SCVO2 are more, it may be some abnormally high delivery of oxygen is there, some rare scenarios like thyrotoxicosis, or your oxygen extraction is supposed extremely less. In cases of brain death, sometimes it can happen hypothermia, mechanical ventilation, or microcirculatory shunting, mitochondrial dysfunction, where there is not adequate oxygen extraction capacity left. So therapeutic intervention accordingly we can do. If we find out that delivery is less, we can try to optimize delivery of oxygen by suppose giving fluid, blood transfusion, give hemoglobin, increase content of oxygen, give inotropes, increase cardiac index, oxygen therapy, and decrease consumption by giving adequate pain relief, sedation, and still mechanical ventilation. So that is the importance of giving mechanical ventilation, gentle sedation in a case of shock. It will decrease your oxygen consumption and indirectly reduce the work of and reduce the load, reduce VO2 by taking away the work of breathing, basal oxygen utilization requirements. So indirectly it helps in that sense. this is how it is delivered. So DO2 and VO2, there is a body has some capacity to extract it. So there is a supply independent area. Here your DO2 is decreasing, but the VO2 is remaining same. But below a certain level, if DO2 falls further, this VO2 starts falling linearly. This becomes the supply dependence area. And during this zone, when DO2 starts reducing, you see that gradually lactate starts rising, and your SCVO2 falls a bit less steep, less dramatic, because the compensatory extraction is more. So as it decreases further and VO2 increases, lactate starts rising, SCVO2 starts falling. So whenever it is in a case of shock, impaired perfusion, if the SCVO2 is normal, look at evidence of tissue hypoxia, organ dysfunction. If it is there, still you try to further optimize DO2 and decrease VO2. If it is high, then if shock is present and SCVO2 is high, then you look at some microcirculatory parameters. You can look at lactate, you can look at central to venous CO2 gap, and you can look at venous arterial CO2 divided by the arteriovenous oxygenation. That will give you how does that work. I'll discuss in further sessions. And also look at echocardiography, invasive hemodynamic monitoring to give us a better idea. So the further sessions are volume resuscitation closely linked to fluid responsiveness. For example, we want to give fluids. The fluids have some limitations. Fluids can be harmful. If it is needed, absolutely give it. In a setting of hypovolemia, hemorrhage, diarrhea, you give it. But in a case of effective circulatory volume is less, be very careful, because there may be a third spacing leaking happening, glycocalyx damage, where we would ideally like to have some parameters where we can assess whether before giving fluid, whether giving fluid will increase the cardiac output. That is the definition of fluid responsiveness. You give fluids and there should be increase in cardiac output by 10%. So we'll cover these things, which is very interesting and relevant, in the next sessions. Thank you.